want you to take a second and just imagine your heart.
Just beating away in there.
Right. Now imagine a specialized layer of fat sitting right up against that heart muscle. For a long time, it's been, easy to think of fat as just this passive insulation, like bubble wrap for your organs.
Yeah, just kind of inert storage.
Exactly. But what if I told you that this specific layer of fat is actually a highly active, incredibly dynamic, and, well, potentially dangerous organ all on its own?
It's a completely different paradigm.
It really is. So today, we are doing a deep dive into this, pitting the two heavyweights of medical imaging against each other. We're talking CT scans and MRIs. We want to see which one can actually catch this killer hiding in plain sight. We're looking at a pretty fascinating medical study called a head-to-head comparison between MRI and CT in the evaluation of volume and quality of epicardial adipose tissue.
And the stakes here are, they're incredibly high. We aren't just talking about stored calories anymore. We are looking at a tissue that actively communicates with the heart. It secretes chemicals, and in many cases, it directly drives heart disease.
Wow.
Yeah, accurately measuring this fat could literally give us the ability to predict major coronary events before they even happen.
Okay, let's unpack this. Because before we get to the multi-million-dollar machines, we need to really understand the target. We are talking about epicardial adipose tissue, or EAT, EAT.
Right, ET.
And this fat lives in a very specific high-rent zip code, right? It's sandwiched right between the myocardium, which is the actual working heart muscle, and the pericardium, which is the fiber sac that holds the entire heart.
Yeah, and that physical geography dictates literally everything about how this tissue behaves, because epicardial fat shares the exact same microcirculation as the heart muscle itself.
So they're sharing blood vessels.
Exactly. There is no physical barrier between the two. They share a blood supply. They are intimately, inextricably connected. And it is really important to realize that epicardial fat is anatomically and genetically distinct from, the subcutaneous fat you might pinch on your waistline.
Right, it's a totally different beast. Reading through the research, the best analogy I could come up with is that this epicardial fat acts like a deeply unpredictable roommate for your heart.
A roommate. I like that.
Yeah, like on good days, it's the best roommate ever. It pays the rent. Because it's rich in brown fat, it acts as this local energy reservoir, providing essential fatty acids and energy substrates directly to the hardworking heart muscle.
Which is the healthy physiological state. It physically and chemically supports the myocardium. But on bad days, as you put it, that roommate decides to completely trash the apartment.
This breaks all your stuff.
Exactly. In certain metabolic conditions like obesity or insulin resistance, this fat becomes profoundly dysfunctional. It stops providing energy and actually starts releasing harmful pro-inflammatory and pro-fibrotic cytokines right into the heart muscle.
Let's drill down into that mechanism for a second. When you say pro-fibrotic cytokines, we are talking about chemical signals that fundamentally alter the heart tissue. Right?
That's it. These cytokines trigger fibroblasts in the heart to start laying down excess collagen. They are literally turning flexible, highly efficient muscle tissue into rigid scar tissue.
Oh, wow. So it's stiffening the heart.
Yes. It is essentially bathing the heart in a chemical cocktail that causes chronic inflammation and fibrosis.
Which explains why we care so much about tracking it, because when that epicardial fat volume goes up and when it gets inflamed, it is heavily linked to severe cardiovascular disorders. We are talking about coronary artery disease.
Absolutely.
We're talking about atrial fibrillation, which is an irregular, often rapid heart rate that drastically increases the risk of strokes and heart failure.
It acts as a localized, highly toxic risk factor. So naturally, cardiologists want to measure it. They need to know the exact volume of this fat sitting on the heart. Historically, the go-to tool has been echocardiography.
A standard ultrasound.
Right, a standard ultrasound of the heart. And echocardiograms are fantastic because they are inexpensive, widely accessible, and take just a few minutes.
But an ultrasound only gives you a 1D measurement, right? I mean, it only measures the thickness of the fat at one specific point on the right ventricle.
Exactly.
It's kind of like trying to calculate the total volume of water in an irregularly shaped swimming pool by just dropping a ruler into the shallow end once. It relies entirely on the angle the technician chooses, and it simply cannot give you the total 3D volume of the fat.
That's a great way to put it. To get true, precise volumetric quantification, we have to move away from 1D estimates and bring in advanced 3D imaging with high spatial resolution. We need the big guns.
The CT and the MRI.
Yes. Computed tomography, the CT scan, and magnetic resonance imaging, the MRI.
Which sets up the central showdown of the study we are analyzing today for you guys.
Right.
We know this fat is a troublemaker, and we know we need to measure its total volume. But if you put the exact same human heart into a CT scanner and then you put it into an MRI, well, do you get the exact same volume measurement?
To answer that question, the researchers pulled data from the Swedish Cardiopulmonary Bioimage Study, or SCAPIS.
SCAPIS, right.
Yeah, it is a massive, incredibly rigorous bioimage database. They selected 92 participants, averaging around 59 years old, and they created a perfectly balanced cohort.
Meaning 46 of them had type 2 diabetes and 46 did not.
Correct.
And that 50-50 split is crucial because, diabetes systemically alters how fat behaves and is distributed throughout the body.
Absolutely.
So they put these 92 people through both a state-of-the-art CT scan and a specialized MRI. On average, the two scans were done about 72 days apart. And when the data came back, the initial finding for the total volume of fat was what statisticians call a very strong positive correlation.
Yeah, the correlation coefficient, or the R's value, was 0.92.
Which is huge.
It is. In medical statistics, 1.0 is a perfect lockstep match. So a 0.92 means that when the CT scan detected a massive volume of epicardial fat, the MRI also reliably detected a massive volume of epicardial fat. They tracked together beautifully.
Here's where it gets really interesting. Even though they trended together, they did not arrive at the same final number. The CT scans systematically measured a larger volume of fat than the MRIs did.
They did.
The average volume calculated by the CT was 130 milliliters. The average calculated by the MRI was 115 milliliters. That is a systematic average difference of 16.2 milliliters.
And that 16 milliliter gap held true across the board, regardless of whether the patient had diabetes or not. The CT consistently came in higher.
I have to push back on this. These are multi-million-dollar, highly calibrated diagnostic machines. If you put the exact same human heart in both, how can one machine find 16 extra milliliters of fat? That's like more than a tablespoon of extra tissue just appearing out of nowhere. Which machine is lying to us?
Neither is hallucinating or lying. They are simply interpreting the physical world using different physical principles. The discrepancy largely comes down to the complex mechanics of how these machines build images, specifically a phenomenon called partial voluming.
Partial voluming. Okay, so both machines construct a 3D digital model of the heart using voxels.
Right.
A voxel is basically a 3D pixel, a tiny microscopic cube of data that makes up the entire image.
Correct. Now imagine a scenario where one of those tiny voxels sits directly on the border between the epicardial fat and the actual heart muscle.
Or maybe a tiny coronary blood vessel.
Exactly. That specific voxel contains a physical mixture. Let's say it's 51% fat and 49% muscle. The computer software still has to categorize that entire cube. It has to make a binary choice. Is this voxel fat or not fat?
It's basically digital gerrymandering.
I love that.
Yeah, if the voxel is a voting district with a slight majority of fat, the machine's threshold might award the entire district to the fat category, even if almost half of it is muscle.
That is a brilliant way to conceptualize it. In CT scans, the categorization is based on tissue density, measured in Hounsfield units.
Right.
Water is set at 0. Bone is highly dense, so it sits way up in the positive numbers, around plus 1,000. Fat is less dense than water, so it falls into the negative range. The CT threshold for epicardial fat is set between negative 190 and negative 30 Hounsfield units.
That's a pretty wide net.
It is. If the average density of that mixed border voxel falls anywhere in that wide negative range, the CT software categorizes the entire block as fat.
So the CT is scooping up all these border districts, but the MRI isn't using tissue density at all. The study mentions they used a 3D Dixon sequence. How does that change the voting rules for our gerrymandered voxel?
The 3D Dixon sequence is a fascinating piece of physics. It exploits the fact that protons in water molecules and protons in fat molecules resonate at slightly different frequencies when exposed to a magnetic field.
Because they're in a giant magnet.
Yes.
Yes.
Because they resonate differently, the MRI can mathematically separate the signal coming from water from the signal coming from fat.
Oh, I see. So instead of just looking at the overall average density of the voxel like the CT does, the MRI is actually reading the distinct chemical signatures inside the box.
Precisely. The MRI maps what's called the fat signal fraction, or FSF. It calculates the strict ratio of the fat signal to the total combined signal of water and fat. Because it is isolating that specific chemical signature, the MRI's threshold is fundamentally stricter.
Right. It's not guessing based on an average.
Exactly. It is actively excluding many of those border voxels that the CT scan sweeps up into its total volume.
The study actually included some striking visuals of this exact phenomenon. They showed 3D reconstructions of the heart where they color-coded the fat. The CT fat was segmented using advanced AI deep learning models, and it was colored bright green. The MRI fat was segmented manually and colored yellow.
And the difference is visible.
It really is. When you look at the 3D models side by side, the green CT model looks distinctly puffier around the edges. You can physically see where that extra 16 milliliters is clinging to the borders in 3D space.
Which is why understanding this mechanism is vital for clinical practice. If a patient is getting their epicardial fat tracked over a 5-year period to monitor their heart disease, their cardiologist cannot bounce back and forth between CT and MRI.
Oh, definitely not.
They have to stick to one imaging modality because a 16 milliliter leap caused purely by switching the machine would look like a massive, terrifying progression of the disease.
So the CT catches extra border voxels because of its density thresholds. That solves the volume mystery. But volume is only half the threat, right?
Right.
I mean, a massive layer of relatively dormant fat might not be as dangerous as a thin layer of highly toxic inflamed fat. How do these machines handle the actual chemical makeup of the tissue?
This is a massive pivot in modern cardiovascular research. For decades, we were obsessed with the sheer volume of epicardial fat. But recent evidence strongly suggests that the qualitative characteristics of that fat, its actual molecular composition, might matter just as much, if not more, than how much of it there is.
Well, let's define the terms here. What makes this fat bad in terms of quality?
Well, in medical imaging, particularly on a CT scan, bad fat has a lower radiodensity. It literally registers differently on the scan. It has more negative Hounsfield units.
Okay, so a more negative number.
Yes. A lower radiodensity indicates that the adipose tissue is more lipid-rich. And clinically, highly lipid-rich epicardial fat is aggressively associated with diabetes, advanced coronary artery disease, and a significantly increased risk of hospitalization for severe heart failure.
So lower density equals a higher concentration of lipids, which equals a higher risk of the fat acting like that toxic cytokine-secreting roommate we talked about.
Yes. But there was a lingering, persistent doubt in the cardiology community. Is that CT density number actually reflecting the true fat content?
Why wouldn't it?
Because radiodensity on a CT can be skewed by other biological factors. If there are extra blood vessels in the fat, or if there is localized fibrosis or edema, water retention that changes the density. We needed definitive proof that the CT was actually seeing pure, dangerous fat content and not just biological noise.
Enter the MRI. Because, as we established with the 3D Dixon sequence, the MRI can directly assess the true tissue fat content by separating the water and fat signals to quantify that fat signal fraction. Right. It is the gold standard for quantifying fat in organs like the liver. So the researchers mapped the CT's attenuation density numbers directly against the MRI's true fat signal fraction.
And they found a strong negative correlation. Their R value was negative 0.73.
Wait, hold on. A negative correlation. If I'm looking for two machines to validate each other, a negative correlation sounds like a complete disaster.
It does sound bad at first.
Yeah, I mean, if they are moving in opposite directions, one machine is saying this is fat while the other is saying this is water, how is a negative 0.73 a win?
It sounds completely counterintuitive until you look at the specific scales each machine uses. What's fascinating here is that a negative correlation is the exact mathematical proof the researchers were hunting for.
Walk us through the math, because on the surface, moving in opposite directions sounds like a failure.
Let's look at the MRI first. The MRI measures a percentage of true fat. So a higher fat signal fraction, say, moving from 0.70 up to 0.80, means there is physically more pure lipid fat inside that tissue. The fat percentage is going up.
Okay, that makes sense.
Now, recall how the CT scanner measures density. It uses the Hounsfield scale where fat sits in the negative numbers.
Right, the CT measures fat somewhere between negative 30 and negative 190.
Exactly. So as the true pure fat content goes up on the MRI, the tissue becomes less dense. Because it is less dense, the number on the CT scan goes down. It drops from, say, negative 70 down to negative 80 or negative 90.
Oh.
Yeah, as the pure fat percentage rises, the density number becomes more negative. As one value goes up, the other goes down. That is your negative correlation.
I see. The MRI is saying the chemical signature shows more pure fat here, and the CT scan is saying my density reading is dropping further into the negative numbers.
Yeah.
They're describing the exact same physical reality using inverted scales.
They're in perfect agreement. This is a monumental validation for the field. It proves mathematically that the slightly ambiguous density numbers cardiologists have been reading on CT scans for years are, in fact, predominantly driven by the actual, true fat content of the tissue.
Wow.
The CT isn't being fooled by blood vessels or random inflammation. Its shifting numbers are genuinely detecting that dangerous lipid-rich fat.
So if someone gets a CT scan that shows high volume and highly negative density, their doctor isn't just guessing based on a blurry image. They have hard proof that toxic fat is wrapping the heart.
Exactly.
Let's bring this out of the research lab and into the clinic. Why does this matter for the listener? Like, what does this mean for the future of patient care?
Assessing both the volume and the quality of epicardial adipose tissue is rapidly becoming a crystal ball for cardiovascular risk. By measuring this fat, doctors can predict major coronary events far earlier than traditional methods allow.
The study specifically highlights that epicardial fat assessment can predict these events even before calcium starts building up in the arterial plaques. We always hear about coronary calcium scores as the ultimate definitive warning sign for a heart attack.
Right, the gold standard warning.
But measuring this fat is looking even further upstream in the disease process.
It is looking at the toxic environment that creates the disease, rather than just waiting to measure the calcified aftermath of the disease itself. Furthermore, the molecular quality of this fat is an independent predictor of whether a patient will suffer from atrial fibrillation again after undergoing a catheter ablation.
To give some context for you guys listening, a catheter ablation is a serious invasive procedure where a surgeon threads a wire into the heart and literally burns or freezes rogue heart tissue to destroy the abnormal electrical pathways causing the irregular heartbeat.
It is a major intervention. But if a surgeon can look at an MRI beforehand, analyze the lipid-rich quality of the fat surrounding the heart, and know with high certainty whether that irregular heartbeat is just going to return post-surgery,
that completely revolutionizes the risk-benefit analysis of the treatment.
it absolutely does.
And this study makes a very compelling case for using MRI as the definitive tool to do this. Unlike CT scans, the MRI doesn't expose the patient to any ionizing radiation, and the reliability of the MRI data is staggering. They ran rigorous repeatability tests.
Yes, they measured the inter-reader agreement using an inter-class correlation coefficient. The score was 0.96.
For those not living in statistical software all day, a 0.96 is considered mathematically excellent. It means if a radiologist manually measures the fat volume on an MRI today, and then measures that exact same complex 3D scan again a month later, they arrive at almost the exact same milliliter count.
The method is incredibly stable.
But I'm going to play devil's advocate for a second. Given how revolutionary this sounds, should everyone rush out, call their cardiologist, and demand a 3D Dixon MRI to check the lipid richness of their epicardial fat right now?
Not quite yet. This raises an important point about how cutting-edge medical research eventually translates to routine clinical care. We have to acknowledge the study's boundaries.
Right.
92 people is a fantastic start for proving a concept, but it's a relatively small sample size in the grand scheme of cardiovascular health.
It's also a single-center study conducted entirely in Linköping, Sweden.
Correct. And they only use scanners from a single vendor, Philips, for the MRI, and Siemens for the CT. To make this diagnostic technique a global standard, researchers need to prove it works flawlessly on every brand of machine across diverse populations in hundreds of hospitals worldwide.
The researchers also noted a significant clinical limitation. They had to exclude people with highly irregular ventricular rhythms, which mechanically makes sense if the heart is beating erratically. Taking a highly detailed microscopic 3D photo of it is going to be incredibly blurry.
Yeah, motion artifact is a huge problem.
But since epicardial fat actually causes irregular heartbeats like AFib, excluding those specific patients means we aren't seeing the whole picture of the disease yet.
And finally, that specific cardiac 3D Dixon MRI technique is highly advanced. It is primarily used in specialized research settings right now. It is not standard in a routine Tuesday morning imaging protocol at your local clinic.
Gotcha.
However, the study proves that with the current settings, the actual scan time and the computer processing time are totally feasible for a busy hospital.
Yeah.
We could realistically see routine MRIs adapted in the near future to safely track this.
So to synthesize all of this, epicardial fat is a major active player in heart health. Both CT and MRI are phenomenal, highly accurate tools to track it, even though CT will systematically overestimate the volume by about 16 milliliters compared to the stricter MRI.
Right.
But most importantly, both tools can accurately gauge the molecular danger level, the actual lipid-rich quality of that fat, giving doctors a powerful, non-invasive early warning system for heart disease.
And if you think about the deep implications of that finding, it points to a radical shift in how we might treat cardiovascular disease. The study establishes that the sheer molecular quality of this fat actively predicts if surgical treatments for arrhythmias will fail.
Wow.
If this fat is sitting there, actively secreting harmful disease-causing cytokines right into the heart muscle, perhaps the future of cardiology isn't just about mechanically treating the heart tissue itself.
What do you mean?
What if, one day, instead of just using MRIs to take pictures of this fat, we develop targeted pharmacological treatments? Medicines specifically designed to alter the molecular quality of the epicardial fat. By effectively changing its chemical signature, we could neutralize its toxicity, stopping heart arrhythmias at their source before the first irregular beat ever happens.
A complete paradigm shift from managing the damage to changing the environment itself. Thank you for joining us on this deep dive. As always, keep questioning, keep exploring, and stay curious.